Hey, Brooke.
Hey, how are you doing?
All right. How are you? I am going to do my afternoon walk and I'll be right back. I just wanted to go ahead and get on the session.
That I'm waiting for Becky, and we're going to upload the slides. So me and her just be here
Okay.
waiting. Okay.
Thank
Thank
you.
you.
It looks like Nancy Marshall must have went ahead and logged in and probably went to lunch because it said 4 hours ago. She
Probably
probably
so.
made sure she'll be in the session. All right. I'll talk to you.
All right, Ladybug. Thank you. Hi,
Can you hear me?
I can hear you. How are you?
I'm good. Do you share the screen like at the bottom?
Let's see. Yeah, you do. Like, okay, so you see where the computer screen is with the red line over it.
Mhm.
If you'll click on that, it'll pull up what you've got open,
Okay.
and you'll be able to share the PowerPoint.
Okay. Well, I'm going to close everything out that I've been looking at today so that.
Love you.
Oh, but are my notes going to show up?
Let's see. Just try it.
Hold on. Let me get out of this mess that I'm in. Okay.
Hey, Kathy, we're waving back.
Is Kathy there? Oh, hey, Kathy. All right. I hit share, and then what do you see?
I don't see anything right now.
Uh-oh. Good thing we're on here.
Mm-hmm. So when you hit the computer screen, it should have brought up what was on your screen. Did you hit that?
I hit the what do you see?
I don't
Nothing.
see anything except you.
Uh-oh. Okay. Well, I have my PowerPoint open on my screen. Share your screen, my entire screen or application window. Okay, here we go. What do you see now?
You're sharing our video chat instead of, so you need to pick the other.
Okay, sorry. Let's see, share. Application window. That's going to show my notes though.
So go back, get out of that.
Stop sharing. Okay.
Open up your presentation and put it in presenter mode.
Uh-oh, I forgot how to do that. Okay, I'm looking at it.
Hold just a minute.
Shoot. I don't want it to do a slideshow because
So where it goes, view.
Kathy's calling.
Good deal.
Hey, Kathy. I do. Okay. Okay. From beginning. Okay. It looks like it. Can you? Uh-oh. Oh, God. I may have to let Brooke do this.
That's fine. If you want to send it, is it the one that you sent me yesterday?
Yes.
Okay, hold on just a second.
Because I see how to change it. I can do all that. But I can't get out of it to get to hop in. I'm going to end the show. Yeah, I think I'm going to have to let Brooke do it. Thank you. I see it, Brooke. Thanks.
No problem.
Yeah, I think, you know what? I've only got my laptop open and I couldn't get
it out because it went that way. I get it. Mine done the same thing. Does that look good?
That looks really good. Yes.
All right, perfect.
And I can hear you just fine and you can hear me. And I think Kathy can.
And I'm going to mute myself and just kind of.
Okay. Let 1:45, right?
Yes, ma'am.
Hello, everyone.
Hi, Andrea. How are you?
All right. How are you?
Doing well. Are you surviving the moderating of all of these little video conferences?
I'm trying. I am trying, and I am multitasking.
I'll bet you are.
You know what next week is?
Mm-hmm.
And I want to be off the 15th and the 16th.
Oh, well, you got to, yeah. Good. I
And
hope
the
you're,
13th in the afternoon, I got the drive-through COVID testing.
oh.
So got a lot going on.
Mm-hmm. Have
So
you guys done a lot of that? Brooke, you're
yes,
on mute.
we actually do it. We started out doing it twice a week, but now we do it once a week because it's dying down. Not as many people, but we're the only one that does it in our area. So we have all different counties, surrounding counties coming.
I'll bet.
Yes.
You're
So
in mute.
yes, ma'am, Kathy. Ada County is due next week.
No.
We got about 15 more minutes. I noticed that people don't start coming in to right on time.
Yeah.
I know Brooke was on our business meeting earlier with you or Kathy.
Uh-huh.
Becca, where you want it?
Kathy, I was not on it. Brooke, you're still not, you were on, I could hear you so clearly when we started.
Are you having technical difficulties? Well, at least we can see you today. Yesterday we couldn't see you.
Okay. She was, when we first got on here, I could hear her just fine.
We did too, because actually I was up here. We got up here I think about 1:15.
Uh-huh.
And we both were talking. I told her I was gonna go do my afternoon walk and I'll be back. So we were having a whole little conversation.
Yeah, everything was good.
But that's how she was yesterday. She was up here, and all of a sudden, when it was time for her to present after Kathy got finished,
Yeah.
we look, where was Brooke? We had to skip over that little section and go on to another session. Then finally she popped in.
Thank goodness everybody is flexible.
Exactly.
I mean, if we have to, I have all the notes too, so we'll be fine.
Yeah, we'll get through it. So how's it going? Have you been in any other sessions or anything?
Yeah, well, I went to their to Kathy and Brooks yesterday, and of course the opening speaker, and then Susan Little's talk this morning. I listened to that, and
what did Susan Little talk about this morning?
just like public health nursing and kind of where it's going, and just little things.
The only downfall of moderating these, you're not able to go to any sections.
Mm-hmm.
And it's been like that for 2 or 3 years now for me. And now that I'm the section chair, I definitely need to be in every one that we do.
Yeah.
So I don't get to venture out much.
You just stay in that office.
Mm-hmm.
I'm realizing I need to do something about the lighting. There you are.
Can you hear me?
Yes.
We can hear you now.
All right, Lana, let me share my screen. Okay. Let's see.
All right, that's LaShonda calling me. Hold on, I'm gonna put y'all on mute, okay?
Okay.
That's
All
good.
right, good deal. Does everything look good now? Can you hear me? I know what I
Can hear.
did. I unplugged my thing.
Yeah, the simplest things sometimes.
It is.
It's like take your battery out of your MiFi and put it back in.
Yes.
I see LaShonda coming in.
Mm-hmm.
Welcome everyone. We're just waiting a few more minutes. Our session starts at 1:45. Before we get started, as you join the session, please put your name and health department or organization you are representing today. Thank you. Hey, Angela, if you could put your organization name or health department name in the chat box for me.
Hey, Angel.
Hey, Angel. Thank you.
Oh,
Oh, well, thank you. Nice to meet you. Well, your name? Kathy, are you a little jealous? You're special too.
Are you ready to get started?
Whenever you are. We got like 2 more minutes before 1:45, but if you want to get started now, you can.
We'll wait. We'll wait the extra 2 minutes. That's fine.
Excuse me. Once you get started, I'm going to cut my camera and mic off.
Okay. Sounds good. I won't be able to cut my. No, I'm just kidding.
Okay. Are you talking first?
I am. I will be speaking first. Yes, ma'am.
Okay. I was going to tell you, do not cut yours off while Becky is talking because we want you to come back on.
Okay. Okay.
Because we don't want your technical difficulties.
Who, mine?
Yeah.
What are you
think
talking
I'm
about?
mine on too.
Hey, Danielle. Hey, Kimberly.
That's all Brook people.
It is. It's the East.
Okay, everyone, we are getting ready to get started. We have the consultants Brooke Johnson and Rebecca Webb with us that will be speaking on the guidance on master and public health fee schedules. Let's give our attention to Miss Brooke.
Hey, I hope everybody's having a wonderful day. Thank y'all so much for joining us today. Becky actually covers the West, and I have the Eastern region. It is so good to be here today, and I know it's a little bit different than what we're used to, but I feel very thankful that we can still reach out and communicate and touch y'all with the public health and be able to communicate. We really do miss the in-person communication, but that will come when we can. So here's our map. We have our map, and you can see that we have, all the consultants, and that map will be changing soon. But as of right now, this is what our map looks like. If y'all have any questions, this map will be changing in the next couple of months due to Kathy Brooks, which is on today. She will be retiring, and we are going to miss her immensely, but we are so happy for her. So give her a congratulations if you see her. So these are the topics that we're going to cover today. The fee settings. How do you set your fees? Why is it important to even set fees? 340B fee setting. What is 340B? There's been a lot of talk about that lately. We actually have changed a lot of that stuff in our code and billing guide document this year. So that's really important to hit on. The sliding fee scale. Fees for women and children health services. Fees for Medicaid patients. Got some stuff going on with that too, don't we? Some of the fee schedules have changed. We've upped some of those fees. Medicaid did. There's just a lot of things going on. COVID-19, vaccines, non-sliding fee scale, venipuncture collection. A lot of information with this presentation. And if y'all have any questions, please put them in the chat box. We're going to try to answer them. And if we can't, we'll take them back, and we will make sure that we have your name and your email, and we will send it back to you. So let's get started. How do you determine how much to charge for your fees? It is legal to charge for your services, and it's okay. It is the North Carolina General Statute 130A 39. Health departments are allowed to charge fees for services in North Carolina. But why do we charge fees? Why? Why do we need to charge fees? The purpose to charge these fees is necessary to help us cover the full cost of providing recommended and needed health services. It costs us a lot of money to see a patient, even for a 99211, which is a nurse visit. So we have to make sure that we get the real base, the cost of how much it really costs to see that patient. And then we can calculate the direct and the indirect costs with that. So the direct cost, here's some examples of your direct cost. That's your salary and fringe, your pharmaceutical, your travel, computers, your devices. That's what goes into your direct cost. Your indirect cost, it's your utilities, your rent, your cleaning, stuff like that, which impacts the health departments because we have to pay the utilities and stuff. So the consolidated, yes.
Yes, want to know if the slides will be shared.
Yes. After this, Andrea, I will actually send these slides to you, me or Becky one, and we're going to make sure, if you don't mind, to get them out like we did yesterday. Is that okay?
That'll be fine.
Okay, yeah, we'll definitely share these slides. The consolidated agreement is signed annually, and it's an agreement between the North Carolina Department of Health and Human Services, Division of Public Health, and the local health departments. The agreement outlines provisions and constitute the terms and conditions applicable for activities for state funding. So that's why that consolidated agreement is so important. So in bullet 1, is that your charge? It's your charge is your charge is your charge. You want to come up with a charge because regardless of who you're going to send your charge to for 99211, if you send them a charge of $100 for 99211, Medicaid's going to pay you 56 something, and Medicare is going to pay you 58. Blue Cross Blue Shield may pay you that 100, but what your charge is your charge is your charge is your charge. Bullet number 2 is the 340B. 340B must be billed to Medicaid at the acquisition cost. Number 3, you may accept contract and negotiation rates as full payment. I know that when I was doing the billing at the health department, we would sometimes bill insurance companies that we were not contracted with, and they would actually send us a form to say, hey, we're not contracted with you, but we'll pay you for our patient, $25 for the service. Might be less than what we charged, but we're actually getting payment for something that we normally would not get payment for. So, you have to decide if your health department would want to do that, but it is a way that you can negotiate payments with people that you're not contracted with at all. And make sure that you're looking at your payment collections. You've got to follow up on that because remember, no one shall be refused service. So if you have a lot of collections sitting out there and you've not worked your denials and you've not got that money, you're not collecting and making your revenue where it's supposed to be. You have to make sure that you're not refusing service due to inability to pay to, and that should be in your policy. You got to make every reasonable effort to collect the charges. And then number 5, review your fees annually. Due to the changes in employment and the cost and the changes in the cost that it provides service, because sometimes a 99211, I know through the 22 years I've been here, I can remember a 99211 being Medicaid would pay you $36 for it. Now they're going to pay you $56 for it. And I might be a little off there, but it has changed over the years. So you need to make sure that you're looking at your fee schedules. So what do we recommend? The policy. Make sure your agency develops a pricing policy and a fee setting policy. This should be part of your fees and eligibility and billing policy. And this way you're establishing your charge is your charge is your charge. You're making sure you've got your customary fees. This is what we charge, and then we'll review it again next year at this time. So there is a sample policy on our website that is like fill in the blank. And we also use that same website to tell you that when we go and do your monitoring, we refer you to this sample policy. We actually follow the sample policy. So that's why we're directing you to it now. If you need to update your policy and you don't want to reinvent it, you can actually pull this one out and it'll give you everything that you need. And you will be able to follow the policy and add it to where you need and what you're missing in your policy. It is also helpful to read through it, like I said, and make sure that if you don't have something in there about the 340B, you can pull it out of that sample policy and then you'll have it. The policy is real good. We have just updated that in the last year. So it is current and it looks good. So once you receive the Medicaid reimbursement fee schedule, and around February, which this year has been a little crazy, I know, but it usually does come out around February. You need to review against your agency's fee schedule to identify the changes that are needed, just like that 99211. If Medicaid says, okay, well, we're going to start paying $100 for the 99211 and you're only charging 56, they're only going to pay you $56. They're not going to pay you that $100. So you need to reevaluate your fees, and you need to do that using the fees committee. So how are you going to do that? So this slide is an example of a Excel spreadsheet that we have done to show you, okay, so you got your fees committee, you're coming on, and we are going to reevaluate all our CPT codes against Medicaid, Medicare, and insurance. And the cost means how much it actually costs to do the service. So what we're going to do is we're going to put our CPT code in, which is a 99211. We're going to make sure we got a description so we know what we're talking about. This is a nurse visit. Recommended cost is what we're saying we're going to recommend the next phase to be. This is not what it is right now, but we're going to recommend that our costs be this. So we're going to say it's $80 is what we recommend. Our cost right now is $60. Medicaid's only going to pay us $34.16. Medicare is only going to pay us $40, and insurance is going to pay us $56.15. But it costs us $150 to do it. So the fees committee is going to get in there and propose the new fee, look at the fees, make sure the reimbursements are correct, and then they're going to come up with this, and they're all going to sit down together and make sure the cost is always going to be more than what is charged. And you got to think of the self-pay population too. You've got a sliding fee scale, and you want to make sure when you're setting your fees and that you're not going so overboard with your fees, even though it costs $150 to do it, that you're not overcharging your self-pay patients, because that is really important, because that could be a barrier of care when you are doing your fee schedules and you are making your committee. And it's really important not to make it difficult for those self-pay patients to come in and they cannot afford their care. Is there any questions on this? Because this is a new slide, so this was new. And this is the sample fee policy. This is what it looks like. So it's the fill in the blanks. So you can go and just fill in your health department, what your purpose is, the policy, and it's like that throughout the sample. So it's a really good guide to what needs to be in your fees, settings, and policies and procedures. And like I said, that's some of the things that we look at when we go and we monitor you guys, okay? And this slide we just put in there because we want to remind everybody to follow your policy. If it's in your policy, y'all need to follow your policy. If you want to do something different, then we need to change your policy or add to your policy. And that's okay. We've just got to get it approved, and we need to remember that too. So how often should our fee setting policy be reviewed? The fees committee, which is comprised of the finance officer, clinical staff, DON, program coordinators, the managers, the billing, the managers of billing, your front desk staff, and if you have the dental, your dental people should review that fees policy. I get my words all messed up. I'm sorry. Fees policy and do that Excel spreadsheet as a group. So what are the do's and don'ts? you may use tools to do your fees as the Medicaid cost study report, because that will give you your actual cost for the services that are being done. You can actually look at the Medicaid cost study report and get that cost, your vendor rates, personnel costs, and it is acceptable to ask other health departments to see if they would share their fees and see what they are doing. Be sure to retain any notes or minutes when you have a fee committee's meeting, because it will be used for reaccreditation. So you'll get credit for that. Remember, you must have an NDC number, and you're charging the acquisition cost, and you have to have a UD modifier when using 340B drugs. So we don't want to take and get in the fees committee and all of us sitting around the table and say, we're just going to do a 5% raise. That's it. We're just going to do that. No, we don't do that. We're going to get in trouble for that. We can't do that because it's not an actual cost of what the CPT codes we are doing. Because that's just, we can't do that. The website that I mentioned earlier, we've added a link to it, and this is the website. This is our website. You can find everything about the fees there, the workbook. There's also some news and notes, and there's short little handouts that will help you with your fees. That is like a quick little guide. Before COVID, we were trying to get those out at least once a month, or it might have been every 3 months. But we have not done one of those in a while, but there are some out there, and one of them was on setting fees. So I hope everybody is having a great time. If y'all have any questions, remember to put it in the chat box. I'm going to hand it over to Becky now.
Hey, everybody. I just want to also mention, as Brooke did, that we really miss seeing you guys in person, and we look forward to a time when things are more normal. They may never get back to what our old normal was, but we really enjoy visiting you all in person. So I'm going to start out with the 340B drugs and devices. As Brooks already mentioned, you are required to bill Medicaid the acquisition costs of those devices and drugs. And the 340B program enables covered entities to stretch federal resources as far as possible so that you can reach more eligible patients by providing a more comprehensive services. The manufacturers who are agreeing to participate in the 340B program, they agree to provide the outpatient drugs to covered entities at significantly reduced prices. And if any of you have had experience ordering these drugs, both 340B and then from a regular vendor, you know those prices are really crazy as far as the reduction amount. The local health department fee for 340B drugs and devices for Medicaid must be the acquisition cost, although you can charge your usual and customary charge for insurance and self-pay. You must use the UD modifier because that indicates that it's a 340B purchased drug when you bill Medicaid. And you also have to have your NDC number, as was already mentioned. So what is the acquisition cost? That's a discounted price that you pay to manufacturers for the 340B drugs. These costs can change as much as quarterly and possibly more. But since the fees have to be approved by the Board of Health or your governing board, it's a good rule of thumb that when you are setting your fees to get approval for the 340B drugs and devices to change in accordance with the change of the acquisition cost. So I just want to say that one more time. That has been a problem that has popped up before, especially when we originally started billing acquisition cost. Just have it written in, have some sort of verbiage in your fee setting policy that says that you are able to change those prices based on acquisition cost. If you do decide, I'm on the fees for 340B drug, there you go. If you do decide to charge a different fee other than the acquisition cost to insurance and self-pay clients, you need to indicate that on the fee schedule by listing out your CPT code for that device or drug and the usual and customary charge for that for insurance and self-pay. But you also need to list the CPT code with a UD modifier that shows the acquisition cost or has verbiage about the acquisition cost. And it is important that you have something in your fee and eligibility policy about the acquisition cost for 340B drugs. That's something that's been missed quite a bit, but it's an easy fix because from our website, you don't have to use that entire fee and eligibility policy. You can take excerpts from it to add to your current policy if that's what you choose to do. Sliding fee scale. What is that? You can attach a sliding fee scale to any program type that you choose to, except for STDs and TBs. Wherever that sliding fee scale is applied, you have to do it consistently all across the program for every person that comes in, to all clients. Now, not every local health department program that's provided has to include a sliding fee scale. For instance, like if you do adult health primary care or you have an other services program, you don't have to do the sliding fee scale with that. If you have a dental center, they do have to have a sliding fee scale, but it does not have to slide to zero. And in the dental centers, it usually is pretty costly to provide services in that area. So most of them can't afford to slide to zero unless they have some sort of grant option or something like that. But anyway, the sliding fee scale is based on your on the federal poverty guidelines, and there is a website at the end that has a link in our resource slide that will show you how to get to the federal poverty guideline website. Okay, next. Okay, this is a slide that's hard to read, but this is the one that's 101 to 250% of the sliding fee scale, and that's the one that Family Planning Program requires you to use. It's provided annually. It's usually the last week of January that we get that, and it becomes effective February 1st. That is provided to us and to local health departments. And again, you have to use this one in the family planning program. There are other sliding fee scales that are optional that you could use in your child health, maternal health, and adult health programs as well. So the next slide is the 100 to 200% sliding fee scale. I don't know if you got, yeah, that's a little better, Brooke. You made that bigger somehow. Okay. It's just really hard to see, but if you guys need copies of these and you can't find them, just reach out to your administrative consultant and we will get you copies of them sent to you. And also it'll be available on these slides later. The next slide is really just the 100 to 300% sliding fee scale. And finally, there's a 100 to 350% sliding fee scale. If some programs like maternal health, family planning, and child health do require that if there are self-pay clients, the fee for that service must slide to zero. I can't stress that enough. Maternal health, family planning, and child health, all those services have to slide to zero. And that is a Title V rule, and it's also on your 351 AA requirements, and it's in the North Carolina Administrative Code. If you are allowed to use a different sliding fee scale, though, for child health and women's health. If you you can't refuse services though to anyone that can't afford to pay. So you need to keep that in mind as well. The next slide is this slide, if you can notice the blue boxes at the bottom of the slide, this is where we went in and we're showing you what a client that comes in for a 99213 would pay based on the federal poverty level and where they fall in the sliding fee scale. The cost on the far right-hand side is a regular charge is $200 for a 99213. If that patient is at the federal poverty level, they would not pay anything. If they are in the 20% bracket, they would pay $40. If they're in the 40% bracket, they would pay $80. And in the 60, 120, and so on. So this is why earlier when Brooke was talking about setting fees, you really need to take into account your self-pay patients, because it really can impact them to a great degree. And you don't want to have a barrier to service because they can't afford to come. Now, the next slide is about fees to your Medicaid patients. This slide is actually from the information from the Medicaid website. And believe it or not, providers, and you may already know this, can refuse to accept a patient as a Medicaid patient. Health departments don't really do that, but if they decide that if a provider does decide they do not want to accept Medicaid as a payer, they have to let the patient know that before they ever render services to them. And they have to let them know that they're going to bill them as a private pay patient. And this is not a rule from the state, it's a rule from Medicaid. So if a provider does accept patients with Medicaid as a payer, they have to agree to take those payments from Medicaid as payment in full, minus the deductible that they might have, or a co-insurance or co-payment. This is really if you have like Medicaid as a payer of last resort. So if you have a patient that has, say, Blue Cross Blue Shield, but they also have Medicaid, you bill the Blue Cross Blue Shield first, then you bill the Medicaid. And Medicaid only allows in certain, Medicaid doesn't allow co-payments in every program. So if you are, I do see a question down there about 340B. So I guess we'll address that in just a little bit. But at any rate, if you do, you have to accept the Medicaid payment as payment in full. You can't just go back and bill your Medicaid patients. Next slide. Okay, again, this is still about billing your Medicaid patients. You can only bill them for, in these situations, allowable deductibles, co-insurance, or co-payments. If you have to inform the patient before the service is provided that they may be billed for a service that's not covered by Medicaid, regardless of the type of provider. And if the patient is 65 years of age or older, and they're enrolled in Medicare program at the time the services are received, but they have failed to apply a Medicare number as proof of coverage. And also, of course, if the patient's no longer eligible for Medicaid. Okay. So, Medicaid providers that don't bill Medicaid patients for Medicaid services if it doesn't receive reimbursement from Medicaid, like if the provider has messed up in the billing or hasn't followed the program regulations, or if it's denied because of lack of proof of medical necessity. And you can't bill the Medicaid patient beyond the previously stated acceptable situations. Now, Medicaid transformation is coming. And we're all studying about that now, and I know everybody's kind of dreading it. So there's going to be a lot of changes coming up in 2021 that we will have to address. And so as we get information and have good information to share with you, we will. Non-sliding fees, what are those? Well, they used to be called flat fees. So the terminology has changed. These fees cannot be offered in the women's children's health program services like family planning and child health and maternal health, because again, those programs must slide to zero. Some examples of non-sliding fees would be like standalone pregnancy tests or TB tests. And by that, I mean, if a patient just comes in for a pregnancy test only, it's not part of another exam that they're having, or if they're just coming in for a TB skin test. So payment for those services that I just mentioned are usually done prior to the service being rendered. So that's probably what most of you are doing. Now, vaccines for children. Okay, if you do decide that you want to charge administration fee for those state supplied vaccines, the maximum amount you can charge for that is whatever the Medicaid rate is on that date of service. So you have to go back and look at your Medicaid rate. If you check the rate, local health departments can check that rate table, and it's provided annually by DPH. Now, if patients say that they don't have the ability to pay, you cannot deny them. So you would waive that administration fee and write that off. You can't deny administration of publicly purchased vaccines to anybody because they're not able to pay the administration fees. And when you do offer those or supply state supplied vaccines, there's a zero charge with that. And you have to use the SL modifier, and that's generally, that SL modifier is showing you that it's a state provided vaccines, but it's also showing the cost report, the people who are preparing the cost report, that has a zero charge, and they pull that out and it isn't part of your Medicaid cost report. Now, purchased vaccines. Again, you have to inform the client of any charge before the service. Immunizations and their administration in this category can be charged to insurance or to the client, and they are not subject to any sliding fee scale. So the health check beneficiaries that are 19 and 20 years of age are not eligible for those VFC vaccines. So that would you would have to use purchase vaccines for those patients. So that sometimes tricks people and, trips them up a little bit. Okay. All right. If venipuncture and specimen collection fees, we've seemed to have had a lot of questions about, especially specimen collection fees right now. If you have in-house lab services at your health department and the lab specimen is collected and performed in-house, so in your laboratory, you can bill Medicaid or insurance for that test. If there's a balance remaining after insurance, the local health department bills the client based on the sliding fee scale. Except for STI labs, you can't charge for that. If they don't have Medicaid or insurance, you can bill a client based on their charge for the test and the sliding fee scale. The local health department can't bill for collection like a 36415 because that is included in your local health department fee for that lab test. So like if you're doing a hematocrit or a CBC or something in your health department, you can't charge them for the collection and the test too. The amount that you do bill for a client for a CPT code for lab work done in your health department should include everything that it takes to provide that service. Like includes your all of your supplies, your cotton, your venipuncture tubes, your needles, any processing and any interpretation of those results. So there's some staff time in there. So that's why you don't charge an additional fee for a venipuncture if it's done in-house. Okay, outside lab performs the test. I thought you were waving at me, Brooke. Outside lab performs the test. So if you have, you collect the specimen in your health department and you package it up and you send it to, say, LabCorp or someone like that, or whoever you have a contract with, that outside lab is going to bill Medicaid or the third-party insurance. You're not allowed to bill those unless you perform those tests in-house. For the self-pay patients, though, if you send it to, say, LabCorp or some other outside lab, you should have a contract with those labs that has negotiated rates for your health department. So the health department would be billed for those patients. You, in turn, could bill the patient based on a sliding fee scale. And and in that case, you could include the $36415 for the venipuncture or the $99,000 for the handling fee. Okay. So free services. You can't have a free service unless the law mandates it, and that includes pregnancy testing. So instead of saying it's a free service, you should slide it to 0. You keep in mind that you have to comply with all of the program rules, which are governed by the state and the federal guidelines. So you can just put those services on the sliding fee scale and just have them slide to 0 based on what your policy states in your health department. So reimbursement rates. The Medicaid reimbursement rates are not negotiable. You probably already know that. They pretty much decide what they're going to reimburse you at, and you'll get that fee schedule based on the reimbursement rate. You do have contracts with your third-party insurance companies, though, and those fees should be reviewed annually, and you can renegotiate those fees. Don't be afraid to do that. A lot of times, the health departments don't even try to renegotiate, but you have the ability to do that, and we recommend that you do that to try to get as much revenue into your health department as you possibly can. Monies are getting tight, as you know, in some areas, and anything we can do to stay viable is, as long as it's legal, we want to do it. All right, COVID-19, everybody's favorite thing this year. The Medicaid fee schedules during COVID-19 have been adjusted, as you know, to a temporary schedule that is during the state of emergency. Next slide. I just want to remind you that we do have the COVID-19 quick guide online at on our website, and that quick guide is updated frequently. And just be sure to take a look at it. It's a living document, and if you look at it, you will see that in red there's like bold new and tells you what's new in it. And as we get updates, we try to get all those gathered and get them out to you as soon as we verified them. So anyway, all the changes that have happened during COVID-19 for Medicaid, they have are only during the state of emergency. The most notable ones is the ability to bill for service that are rendered telephonically without the normal limitations. This also goes along with Medicaid having increased their reimbursement rates for specific services. And we sent those reimbursement rates out to you earlier in the year. They've increased them as much as 45%. So it's really important that you try to keep abreast of those things, do look at the quick guide when we submit it. There's a lot of good information in there. Specifically, these rate changes were in Medicaid special bulletins like number 32, 80, and 123, and also the dental folks, they got a temporary rate increase as well. Okay, now Kathy has a note in here that says the slide does not refer to the codes to bill for COVID-19 related. That's yes. Yeah. Just go to the quick guide for those, all the other things on COVID-19. We have a lot of changes in public health besides COVID-19, if you can believe it. And it's kind of hard to remember pre-COVID, but we're having reduced funding. We did have reduced Medicaid earnings. Now, a lot of the things that are happening during COVID, your cost settlements are going to be affected because your cost settlements are paid to you based on your paid Medicaid rates. So that hopefully the increase in those 45% increase in Medicaid reimbursement rates hopefully will help that. I hope it doesn't have the opposite effect. We also have a decline in number of services divided. The costs are getting higher that are associated with these services that we're rendering. It always costs. The health department does so much extra with patients than happens in a private practice, trying to do like a whole person sort of almost like care management, even when they're coming in for family planning visits or maternal health visits. But you guys and our public health really puts a lot of work and effort and a lot more time into visits with patients than you might find in private practice. So we really want you to take a lot of time to really review your fees and what you're charging. Go back to our website as much as you can to take a look at things that are on there. Take the time to do that because we've done a lot of work there that we hope will make your life a lot easier. If you find out that you're looking at some of these items and you're feeling like, I just don't really know how to go about this, and you think I need a little more training in whatever it is, shoot us an email, ask for it. Just say, we're having a problem with wrapping our heads around COVID-19 or something else. And I'm sure there'll be a lot of training coming up during Medicaid transformation next year. This pretty much wraps up what we had planned, except for any questions that might come up during this time. Andrea, have you seen any other questions over there? I think Kathy answered one of them. It's so small on my screen, it's hard for me to read it.
Yes, I think Kathy answered the question that Danielle had.
I think so.
Okay. Too. I don't really see any others yet. Okay.
Can you, in case everyone didn't read or don't have their chats up, can you read the comments that Kathy says so everyone can hear it?
Sure. Okay. I can't even see it.
Do you want me to read it?
Okay.
Yeah.
Would you like me to read it? Okay.
Can y'all hear me?
Yes.
Okay.
Yes.
All right. So Danielle says, when did the guidance change stating the Medicaid change for 340B drugs should be included on the fee schedule? The last memo received in March stated the 340B Medicaid charge should no longer be included in the regular fee schedule, which is true. The memo from Amanda Fuller-Moore stated from the state pharmacist did state that 340B rate no longer needed to be on your fee schedule. However, to ensure that your agency is billing the correct amount, the ACs, which is us, do review your fee schedule to see that you have the correct amount listed for the 340B drug and that it is different than what your regular fee is. So Kathy answered that. Thank you, Kathy. I really appreciate that. So that's where that was. And some health departments don't put them on their fee schedule. Some of them do. And it just makes it easier for us to check when we're monitoring and making sure that you're billing that 340B acquisition cost. And then on the other note that Kathy wrote was just to make sure that when we were talking about the lab services and we were talking about some of the fees, I'll accept that one COVID slide, that we were not talking about COVID-19 related services with the labs. If you have any questions about the COVID-19 related services, then you would go to our website for the COVID-19 billing quick guide, and that will direct you and have our most up-to-date information so you can bill correctly. And like Becky said, if you have any questions, you can shoot one of us an email that's in your region, your consultant, and we will be glad to answer your questions.
Okay, thank you.
Mm-hmm.
Okay. Well, if we don't have any further questions, this session will be over. We would like to thank Rebecca and Brooke for their time and their information on the fee schedule. We will stay on for a little while longer in case anyone else have any questions. Thank you.
Thank y'all so much. Thank you.
Have a great afternoon.
All right. Well, Becky or Brooke, just whenever y'all get me that PowerPoint, I'll get it over to Kim so she can put it on the website. It probably won't be till next week when she put it on the website.
Okay.
Okay.
Put them up there.
Thank you.
All right. Thank you, ladies. Enjoy.
Thank you so much.
Bye.
Bye.